So greetings, everyone. I'm Suzanne Peters, founder and CEO of Peters Associates, and I'm a proud member of the board of directors for the Women's Funding Network. I'm the secretary for the board. Thank you so much for joining us this afternoon. We're so excited to have you all joining us today from around the U.S. as well as around the world. I know you'll agree that this has been an amazing day of sharing powerful work of women's funds. Let's continue moving forward with stellar content and meaningful conversations together as we get started with the next segment. This concurrent session is The Face of Black Maternal Health. Let's welcome our panel of experts. I'll let the speakers take it from here. Thank you.
Thank you so much. Well, I am Ashlei Spivey, and I'm the director of Ivy Black Girl, and super excited to be here with my amazing colleagues and friends in this work as we talk about the face of Black maternal health. This is going to be a conversation, okay? So make sure that y'all use the chat. We'll try to bring your voices in, answer your questions, but we really want to have a critical and important dialogue about the work around maternal health and centering Black women and birthing folks. Before we dive into our presentation, I would be remiss if I did not acknowledge the land in which we occupy. And so we are in Nebraska. So that means we are occupying land of the Omaha and Sioux tribe. So we want to acknowledge, affirm, think about the value add, the sacrifices, and the experiences of the Indigenous community here in Nebraska. As we're having this conversation about power dynamics, about systems of inequity, we can't do that without acknowledging the land that we are actually on. So with that, let's go ahead and dive in. I want to give a little bit of context and background to what is Ivy Black Girl, just in case y'all haven't heard of us. So we are a Nebraska-based collective that really exists to create space for Black women, femmes, and girls to access and reach our full potential. We started super organically in 2017. We do lots of advocacy work, convening, organizing, collective investments, and resource redistribution, really around the topics that are being discussed all today. So around economic liberation, about reproductive justice and our freedoms, about leadership opportunities and what does that mean for us. And we are sponsored, fiscally sponsored by the Women's Fund of Omaha. So those are our homies in the work. So thank you, Women's Fund of Omaha, for all of your support. So with that little grounding, I would love to invite Jessica to give a background about herself, and then she will take you through her amazing presentation, really to ground us in the structural inequities within the maternal health system.
Thank you so much, Ashley. Good afternoon or good morning, depending on where you are tuning in from. My name is Jessica Ehule. I am on the work group for the Black Maternal Health Work Group for Ivy Black Girl. But I also am the director of programs at City Match. If you've never heard of City Match, we are a maternal and child health organization. We're based at the University of Nebraska in Omaha, Nebraska. And I bring greetings, as Ashley did, from the Omaha land in Omaha, Nebraska. If you do not know where you're from, I put a little link in the chat to click on that and just put in your city and state, and it'll tell you whose land you are on. And so in our work with City Match, we work with local health departments to build their capacity around addressing maternal and child health disparities. And we do this in a number of different ways, through actual capacity building, through training programs, but also through some of our projects. And we have an annual conference as well. And so also in my role at City Match, one of the things we like to bring to the forefront is the data. Of course, the data is very important. What are we actually seeing? So I'll be bringing a bit of that today. But then we also always like to point people to the why behind the data. And that's important to understand the root causes of what we're seeing. So what I'll cover in my presentation today is a little bit of the data that we're seeing, the science behind it, and also the historical components that have led to the inequities in maternal and child health outcomes that we see today. Next slide, please. So just overall grounding for anyone that's not in maternal and child health, or MCH. I might slip and say MCH. I just mean maternal and child health. It's just the acronym. Some background information so that you know. Maternal mortality is defined by the World Health Organization as a death of a woman anytime during her pregnancy or 42 days after the termination of the pregnancy. And that can be from a number of different things. It does not matter where that pregnancy is taking place. So it can be an ectopic pregnancy that's outside of the uterus. That would still be counting as a maternal mortality case or event. So that is how it's defined by the World Health Organization, just to root everybody in where we are. Next slide, please. So to give a picture of what has been happening across our nation, unfortunately, over the last several years, we've been seeing an increase in our maternal mortality rates in the United States. As of 2019, the US is measuring at a 20.1 maternal mortality rate, my apologies, out of 100,000. That is significantly higher than the 2018 rate of 17.4, and it's only been increasing. If you go back and trace 2017, 16, we're going in the wrong direction as a nation. When that data is then disaggregated by race, we find a huge disparity. There's a huge gap in what is happening when we compare Black women with white women across the nation. And you will find that these numbers are even greater when you look at them at the state and local level. So unfortunately, with maternal mortality, we're seeing this like positive incline, but that disparity also is increasing as well as we go along. And so those are two big issues that we need to address. Next slide, please. Before I dive into infant mortality, I would just want to note that the numbers that we see with maternal mortality are not inclusive of our maternal morbidity rates. So our near deaths or, severe maternal morbidity rates, those pieces of data aren't captured as well. We just don't have the systems in place that are keeping track of what's happening with women soon after birthing their child. So we have data that tells us that we're not doing that well, but we don't have very good inclusive data of what's happening as far as morbidity. I wanted to bring up this graph here of infant mortality. And when I talk about maternal mortality, I like to talk about infant mortality as well. One, because infant mortality, just so you know, base definition, is the death of an infant before their first birthday. So any baby that we unfortunately passes before reaching their first birthday will count as an infant mortality death. And I like to bring in maternal mortality and infant mortality because they kind of go hand in hand. Infant mortality is used globe-wide as an indicator of how well we are taking care of our people in our nation. The United States overall infant mortality rate is, I believe it is around 5 in the United States overall, about 5.6. If you just look at overall infant mortality rate, that's not that great, honestly. We're not doing the best job. If you look at nations that are comparable to us, like Canada's at 4.5, and then we have Japan who's doing a lot better than most of us around the globe with the infant mortality rate of 1.9, and that happens for various reasons. This graph here that you're looking at is from the CDC, and this is our 2018 infant mortality data across the nation, disaggregated by race. And so I just told you that the infant mortality rate for the US overall is 5.6. But if we look at our non-Hispanic Black infant mortality rate, it is almost double, not quite, but 10.8. And then if we look at our Native Hawaiian or Pacific Islander, there's still a huge disparity there, as well as with our indigenous populations and Alaskan Natives. So if you look at all of those pieces, like we really are seeing just huge disparities in our infant mortality rates. Those things we're also seeing with our maternal mortality rates as well. So I just want to ground us in, this is the data as it stands right now. This is what we're seeing, and the numbers aren't necessarily getting better with the impact of COVID. That is also having an impact that we probably won't get the true numbers for a couple years, but we know that COVID will also have an impact. Next slide, please. All right, so the Black infant mortality rate, like I just said, is 10.7. But I wanted to point out what's happening locally in the state of Nebraska. So the Black infant mortality rate, like I said, overall is 10.7. But in Nebraska, if you look at the state, that same type of like almost double disparity exists. When you go down to the local level, like if you look at the infant mortality rate in Douglas County, the Black infant mortality rate is actually double that of the white infant mortality rate. So the more you get down to the local level data, it tells you a clearer picture of what is actually happening in that community, and how people are being impacted in various different ways. I think that the largest threat that we know that we're seeing out there is the lack of access to disaggregated data. So what we have is probably not the true picture of what's happening across the nation. A lot of data isn't getting reported into the actual streams that they need to get reported to so that we know what's happening. So sometimes it's not being collected. How it's being collected in various hospitals or birthing centers varies way too much. We don't have a standardized and expected way of everyone to collect this data. So some places are collecting what's happening by race, some places are not. And so when we're trying to get data, we just have too much variability. And so the quality of data isn't that great. And also, we need to, once we have that data, disaggregate it for it to tell us the full picture. So look back at what I told you at the beginning with the United States. If we just looked at the infant mortality and maternal mortality of the United States, we'd say, okay, we're not doing horrible. We're not doing so bad. But once we start disaggregating that by race, we find that in actuality, we have similar Black infant mortality and maternal mortality outcomes as you would find in some countries who don't have as much access to resources and opportunities for healthcare. So just keep that in mind as we go along. Next slide, please. So with all of that, I hope that you are kind of like struck by this data, like why is this happening? I hope that you are starting to wonder what's happening here. What can we do about it? Why do we even have these disparities across racial lines? Next slide, please. So I'm going to talk about a few different framings so we can think about how health happens. One thing I want to say to start off is health does not happen in a vacuum. There are multiple factors that impact our life and our health outcomes that we see. So one perspective that we use in public health often is called the life course perspective. The life course perspective was introduced by Dr. Michael Liu. He was at a time over the Maternal and Child Health Bureau with HRSA. And it really looks at the health outcomes of an individual being across a number of different areas. So we are the result of what's happening in our environment, biological factors, behavioral factors, psychological factors, and social factors. All of those things play into the health outcomes we see, whether that be your maternal health outcomes or just your everyday, if you think about health outcomes as far as your overall like heart condition or other major organ conditions, or your actual mental health and how you're able to function in the world. All of it's impacted by what we're going through day to day. In the life course perspective, it notes that there are protective and risk factors that combine to shape how an individual will have, or what health outcomes an individual will have over their lifetime. Not only that, it takes into account the health of one's mother or father, so the generation before, your health as an individual, and the next generation's health. Understanding that whatever happens to us as individuals in our life journey and our health has been impacted by our mom and dad's health, and our children's health will be impacted by what has happened to us. So it's not just me singularly making these decisions. There are other things outside of us that can result in the health outcomes that we see. Next slide, please. The other piece that I would like to introduce is, if you all have never heard of this term, intersectionality. All of what I'm talking about right now really just has to do with intersectionality as well. This is a term that was coined by Professor Kimberly Crenshaw in the late 80s. And it's a framework for understanding how a person's identities combine to create access to opportunities for access to opportunities or exposure to discrimination throughout their lifetime. So we aren't just our race, right? Our race is also a social construct, so I will say that, and we will talk more about that. But we are a race, but we're not just that. We are different genders. We have different types of religions. We are a part of different classes, different physical abilities, different mental abilities. All of those things make us individuals and who we are. And we also can't run away from the fact that the combination of those identities can make it more or less difficult to navigate in this country, especially all over the world, but definitely in the society that we live in. And that exposure to opportunities or discrimination will have an impact on our overall health outcomes. So that is what we mean by the intersectionality. It's not just race, it's not just your religion, it's not just that one thing, but it's everything that's combined to affect how you can move through the world and what opportunities come your way or what other adverse exposures you may have. It's all based on that. Next slide, please. The other piece that I brought up here is social determinants of health. So I really want to frame us in this life course perspective, understanding that we are all within, we live intersectional lives with a bunch of different identities that help to, will shape how we are able to navigate through life, but then also social determinants of health. Social determinants of health are defined as the conditions and places in which people live, work, play, and it also can affect the health outcomes that we see. So if we think about educational access, neighborhood and built environment, economic stability, access to quality healthcare, and whatever your social units may look like, all of those things will affect your overall health outcomes. I will talk a little bit more today about education, economic stability, and the neighborhood built environment pieces a little bit, and when I get to some of the historical pieces, but these are all components that we would think are external to what's actually happening in your body. So a lot of time we think about health as what an individual is doing, just your physical health or what you're putting into your body, but everything happening around you also has an impact. Next slide, please. All right, so this is a little bit of science. I'm not going to drop too much, but I just want to also put us in that space of understanding what is happening at that level. And you can go back to the other slide, Ashley, that's fine. So if you've never heard of this, there is a hypothesis called the weathering hypothesis. It was introduced by a professor out of Michigan called Dr. Arlene Geronimus. She's still doing this work. But basically, she has, over several years, done a lot of research on the excess morbidity and mortality we're seeing in Black people and trying to understand why this is happening at the cellular level. Weathering is due to an accumulation of stress. We all experience stress. Stress actually is a normal human response that needs to come in, especially if you need to like hurriedly get away from something. So if you were being attacked by a bear, your stress levels need to go up. It turns on all the other channels in your body that say run, and turn off all the things that you don't need to use right now and just get away. Those things are important for us as functioning people. However, if your stress levels never come back down, that becomes toxic to the body. And so that's when we hit what we call toxic stress. And there's an allostatic overload, like your stress is just turned up too long, too high. And this accumulation of stress could be due to several factors. That could be financial factors, employment, what's happening as far as family dynamics, your environment, and what you're just exposed to day to day. So there are several different reasons why we see this. Next slide, please. So in relation to what we see with Black women, studies have shown when we really look at the science behind it. So we all have DNA, and it's not that your DNA like sequence is changing, but what we're finding with weathering is everyone has chromosomes in their body, and you have telomeres on the end of your chromosomes. Everyone has them. Over your lifetime, with you aging, your telomeres deteriorate. That is natural with aging. That is something that happens. However, what Dr. Geronimus and her team saw is that there is premature deterioration of those telomeres at the ends that is not explained by age or other things happening. And that's the weathering that we're seeing. The deterioration has been found to be greater in women in the United States that perceive bias or racism. There's been research on that. based on women who have perceived bias or racism, what has actually happened on the end of those telomeres. So living in a race-conscious society has caused that premature deterioration. When you have that and your cells are basically aging faster than they should, that then can impact your birthing outcomes, your reproductive health and your birthing outcomes. So that is what we are seeing. So oftentimes when a Black or brown birthing person is like, I would like to now plan to get pregnant, they're probably starting at a place where they could have more adverse outcomes just because of all that they've experienced over their lifetime. So remember, we said that life course perspective looks at the grandparents, or your parents, your health, and the next generation, right? We put that into that box. We also talked a little bit about the intersectional identities and how those things can give us opportunities or expose us to traumas, right? And so when we think about what people go through over a lifetime, looking at your social determinants of health, all of those things, those impacts, they go somewhere and they go into the body and they actually affect how your DNA expresses. So not the sequence. It actually changes how your DNA phenotype, so how it's expressing whatever it's supposed to do. That can then impact your health outcomes and all other outcomes we see, not just our birthing outcomes. If you look at like heart conditions or premature death or whatever for other reasons across the board, you will find similar outcomes. And epigenetics, that trauma that we're talking about, think about life course theory, it carries across generations, and it's not due to an individual making decisions either way, right? About like, it's not necessarily that they did something to their health. It's more so what's happening outside of them that they don't have any control over. So this is real. And I want to just ground us in this so we understand the science behind it. Okay, next slide, please. So one other thing I wanted to make sure I mentioned, and I do this in all presentations. I hope that one thing that you all can get from what we have here is an understanding that it is racism and not race that is a risk factor. I want to talk a little bit, just very quickly, about a couple historical policies that have led us here. So not only do we have the science, but we actually have historical pieces that help us to understand what has happened and how we've gotten here. So there are policies that have shaped how people are living today. One of the things I mentioned when going through the social determinants of health was that neighborhood factor and that economic ability or the economic building. One policy piece that has impacted folks' access to housing and access to wealth building is redlining. If you've never heard of redlining, it was a practice done in the 30s or so where banks kind of redline, and there were different color coded, but redline areas that were like least desirable, but also did not allow banks to lend to Black families in particular that wanted to buy houses during that time period. So I would argue that redlining or the effects of redlining are still in place. If you just look around you, they are still happening. But this was actually something you can go back and look into. Go to your town, your city, wherever you are in the United States, find your redlining map, and then put your redlining map over like your educational schools and what are rated your great schools, or put it over like any information you might have around waste sites and things of that nature. Map it over. If you do this across the country, you'll actually find that those redlining practices impacted everything, not just economics and ability to have housing, but education, actual health outcomes, everything. If you map it over any other similar type of map that we have over any city. So redlining has been a huge thing when it comes to the ability of families to have stable housing, but also just build wealth as a family unit, right? And make sure that people are taken care of across their life. And so if we think back again, we said that toxic stress, one of those factors could be financial issues or family stability, all of those things. And if you don't have safe and stable housing, or if you don't have access to growing wealth and you're just trying to do what you can to make sure your family is taken care of, how much more stress is that adding to your plate? What type of impact is that then having on your health when your toxic stress levels are just building and building and building, and you reach this like allostatic overload? So that's one piece. The other piece that I want to bring in just really quickly around policies is the medicalization of birth. There are two pieces that I'm not going to get super into because of time today. But one is the Shepard-Towner Act. The Shepard-Towner Act and the Flexner Report. If you don't know about those, I highly recommend reading up on them. But in synopsis, basically the Flexner Report put in standardized ways of providing healthcare across the US and Canada, and that was necessary. However, as a consequence of that, there were 7 historically Black colleges or universities at the time that trained Black medical professionals. When the Flexner Report came in, 5 of those 7 closed, leaving only 2. And at that time, Black people could only access care at hospitals that cared for Black people. They couldn't go to the whites-only hospital at the time, or they had folks in their community who were providing that healthcare for them. So if we had 7 and we took it down to 2, how many Black healthcare professionals can we produce for a nation of Black people that can't seek care at a facility that says it only takes care of white people? And what impact does that have on health over a lifetime? And how and where are people seeking that care? So that's one. The other piece that I brought in was the Shepard-Towner Act. That regulated obstetric care in the United States, which was also necessary. However, at the time, there were doulas and granny midwives and lactation consultants in communities that were part of the community that provided obstetric care. So when Black birthing folks were given birth, there was a community of folks that came around them and served them during that birthing process and thereafter and beforehand. So there was during and postnatal care that was already built into the community. When we brought in the Shepard-Towner Act and standardized care, we made it illegal, basically, for the granny midwives and the doulas and the lactation consultants that were already doing this work to continue to practice in that way, because we were standardizing care, but we weren't standardizing care for everyone. So those are 2 pieces that really have had an impact on the maternal and child health outcomes that we're seeing. And really, when we think about maternal health and the fact that our maternal morbidity and mortality rates are rising, it links back to the science. It links back to the history. This isn't new, or there isn't something like random that's happening. And so I just wanted to ground us in this is what we're seeing and this is why it's happening. Next slide, please, real quick, Ashley. I wanted to bring this up, and I'm sorry it's not super clear, but I bring up that fact that it is racism and not race. And we use race all the time and say like, oh, race is a risk factor for this, this, and this. But if we think of race as a social construct, our language is actually incorrect. It's not race, but it's the impact of racism on certain people that have led to these adverse health outcomes we're seeing. This chart here, especially on the left-hand side, I'll push you over there. Down at the bottom, it's talking about the psychological stress and unhealthy behaviors and things that we see that we often like cater our healthcare to. So we often want to treat the result of what we're seeing. But what we really want to do is kind of go back a little bit and really look at what's happening at the root. Why is this happening? So we talked about all those disparities in the data and the numbers at the beginning, but I wanted to really go into the why. What has happened at the root cause level? So when we think about addressing white supremacy and racism and class oppression and gender discrimination and exploitation, it's those root cause things. It's those things, those policies that were put in place. Those are the things we really have to address. And that is the way to really do some transformative change in our birth outcomes that we're seeing, is to really get down to the root cause, do the really difficult work, but the really necessary work in order to take care of maternal and child health populations across the nation as we really wish to and should. And with that, I will turn it over to Christian.
Thank you. My name is Christian Minter. I'm an organizer with IB Black Girl, and I have been involved with the collective's Black Maternal Health advocacy for the past year. I'm also a member of the Black Maternal Health Coalition, and I do work for Marta Dimes as the manager of maternal and infant health initiatives for the state of Nebraska. However, today in my presentation, I'm representing my work and role with IB Black Girl. Next slide. So in doing health equity work, it's important to have a framework and an approach to guide you and measure your actions. IB Black Girl does its maternal health advocacy through the lens of reproductive justice. So this term was invented by a group of Black women who established the organization Sister Song. It's defined as a human right to maintain personal bodily autonomy, to have children, to not have children, and when a person does have children, to have the right to raise them in a safe and sustainable community. So reproductive justice is holistic in its approach. Jessica already mentioned some of the social factors that impact health. So when addressing Black maternal health, you have to look at the big picture. Is it access to healthcare options equitable? Are communities safe? Are there livable wages, equitable access to healthy foods, affordable housing, childcare, and neighborhoods free from toxins? All of these social factors speak to impact maternal health are just as important as clinical care. So reproductive justice takes all of this into account. Next slide. So in fall of 2020, IB Black Girl established the first Black Maternal Health Coalition in Nebraska. And the mission is to center and uplift Black women and birthing folks as we work to improve health outcomes in Nebraska. The membership is 80% Black women and includes representation from healthcare systems, state agencies, nonprofits, public health researchers, and community-based programs. It's an opportunity to share updates, determine local priorities, and strengthen collaboration for a collective impact in addressing health disparities. The Nebraska community is like many other places, often struggles with silos in effort and resources. So within the past year especially, we have seen more small nonprofits established in our state to address the health and well-being of Black birthing persons and their families, as well as larger institutions that are implementing their own initiatives. So many folks are doing similar work, and the coalition provides space to share our goals openly, discover opportunities to work more closely together when priorities are aligned, and identify gaps where there is a need that no one has addressed yet. Next slide. So some of our most impactful work so far has been related to public policy and advocacy. And the first one I want to talk about is related to Maternal Mortality Review Committee. So within the last year, a bill was introduced to improve some of the processes for our state Maternal Mortality Review Committee. And the reason why this is important is because this review committee is responsible for tracking the number of maternal deaths in the state and identifying the contributing factors to those deaths, and then making recommendations that can be used by anyone in the state who is providing care to pregnant persons. Our Maternal Mortality Review Committee was lacking in diversity. It was very heavy in, still is a little heavier in clinical expertise and lacking in racial and ethnicity diversity. And so when this bill was introduced, it provided an opportunity for us to provide feedback to the legislators, recommend some edits in language in the bill, but it also opened an opportunity to collaborate directly with the Nebraska Department of Health and Human Services, who is responsible for coordinating maternal mortality review. And so we're able to collaborate with them and work together to develop a new process, a new form for recruiting members. And so with that new membership form, the goal was to develop more diversity related to race, ethnicity, geography, professional and personal expertise, as well as other characteristics. It's really important to have a diverse committee so that you're able to see all the different factors that are contributing to maternal death. When you have only a few perspectives represented, you're able to miss a lot. And as Jessica has already mentioned, there's so much intersection between health and the world around us. And so when you have that personal and professional expertise and the diversity, then you're able to see all the different ways that our system and our community is impacting health. And you can create better recommendations to prevent those deaths in the future. So as a result of that work, DHHS has recently completed a recruitment for additional members. And so we achieved one of our goals in increasing the representation of Black members in the pool of applicants and membership. We've also been collaborating with the Nebraska Perinatal Quality Improvement Collaborative by participating as part of their working group that's developing a pilot project to improve access to data on severe maternal morbidity. As Jessica mentioned, our state is lacking some comprehensive maternal health data. And so we know from national data that Black women are at 2 times higher risk of severe complications of childbirth compared to white women. And so when we lack that data in our state, we don't know what's really going on. And then we don't know, we can't really create solutions that are effective. And so it's important to us to be involved in this work. And we want to make sure that not only is data collected and shared, but it's also broken down by race and ethnicity. So that those who we know have experienced inequities in the past, we want to make sure that if they are experiencing inequities in this area in our state, we're able to identify it, address it, and hold our leaders accountable for making sure that solutions are equitable across the board. So this is an ongoing project that we're still working with. We have other opportunities to provide feedback to legislators on bills that impact maternal health. So some of those prior opportunities include conversations with legislators before the bills are introduced, providing position letters and testimony after legislation is introduced. But we also provide education for legislators who desire to learn more about how systemic racism impacts maternal health and how their policies can help dismantle systemic oppression. So earlier this year, we had the opportunity to provide a lunch and learn on this topic for members of the Nebraska Legislature Health and Human Services Committee. It was well received, and it was very helpful in helping them understand some of the testimony and letters that we had presented for one of the bills. There were some questions afterwards about how systemic racism plays a role in maternal health. So we were able to answer some of their questions and give them additional knowledge as they approach this topic. Because we know that even though folks are in positions of power and in positions of creating legislation, sometimes they don't always have all the information they need. So we step in that role and can give some additional information as how it relates to the experience of Black birthing persons. And that's the end of my section.
Thank you so much, Christian and Jessica, for taking us on that amazing journey so quickly, right? It's so nuanced and so complex. And you both were able to provide grounding and context in science and history and systems, and then really highlight what we're doing locally in Nebraska to really address some of those systemic inequities. And so now we want to open up for questions. You see some notes in the chat for me about dropping your questions in, but we want to be able just to create some space for some Q&A so we can make sure that this is a collective learning environment, right? And we can dialogue around Black maternal health. So I will give a few minutes for folks to start to drop those in, and then I will present them to our wonderful panelists. And if you're not familiar with Hopin, you should see different kind of toggles at the top where you can see who's in the session, if there are any polls, and then you'll see an option that says chat, and you can type in that box. All right. Well, if there's no questions, we are going to leave you with some call to actions, right?
Actually, really quickly, I'm just going to ask this, and if you can type in the chat. I see a couple of people in the queue. Did Francois, Adeline, or Emily want to come up to ask a question?
Okay, I can't see that. Okay.
Yeah, that's okay. I'm just, if you did want to come up to ask a question, just put it in the chat over here. It's possible that you just clicked on it and you didn't mean to, but I just wanted to ask if any of you wanted to ask a question. Okay. Sarah has a question.
Okay. So Sarah's question is, I've noticed in my personal experience that many people in particular, many Black men I met aren't aware of these statistics on Black maternal health. Do you have any tips on how to educate people on this issue?
So that's a great point, Sarah. I would argue that people don't know this. If you're not working in the maternal and child health space, you're not aware of these statistics at all. And so I think that part of it is educating people across the board of what's happening. And it doesn't matter like racial group, what have you. I've talked to several people and if they're not in the field, they're not aware that this is happening. So I think that there has been more awareness brought around what's happening with maternal morbidity and mortality, in particular, due to some celebrities coming out and telling their stories and their experience around some of their health outcomes and like how bias played a role in all of that. So Beyonce had a story about what happened with her, Serena Williams. But I promise you, if you speak to any of the women in your life, any Black women in your life, I promise you'll find someone who's actually had a birth story. You'll find somebody who has had an adverse experience of some sort. And it's not a great thing to say, but I think that there's just not a lot of conversation in the community about what's happening. And so I think just starting to have those conversations, letting people know that, your baby that was born too small isn't just a trait that's in your family. So not only is like a maternal mortality and infant mortality thing, but even things such as preterm birth or low birth weight are adverse birth outcomes that people think is a normal happening that actually could be happening due to some of these factors that we talked about today. So I think there's multiple things we need to do. We need to educate ourselves, right? Have these conversations in community, start talking about these things, not only amongst like Black men, I would say amongst all people, amongst all Black people, amongst all folk period that are out there, just so that we know these disparities are happening amongst Black and brown populations, and making that a topic that people don't forget about. So there's a lot of other topics that could come to the top and people will grapple onto that topic, but making sure folks center, and I think to Ashlei's point and the purpose of I Be Black Girl, it is centering Black women, girls, and folks. And that's what we have to remember to do, because oftentimes in our society, we can put Black women, girls, and folks at the bottom of the list to get to. So how do we bring that conversation up? Because this has been happening for so long. So I think it's multiple things, Sarah. We just need to begin to have the conversations. If there are folks locally in your area who are experts or doing any work in this, if you have community conversations or gatherings, look at other places where you can leverage to have these types of conversations locally.
Yeah, one thing I'll just add before we go to the next question, what we've tried to do with I Be Black Girl is really create space for those narratives, because we know that everyone's birthing experience is not the same. And I think, Sabrina, you named that in the chat, like, I think it's normalized the issues that we have, and we just kind of take them and roll with it and continue to, navigate, versus like pausing and say, this was my experience and that didn't feel right, or this did feel right. And then other people dialoguing with you, especially Black women and birthing folks. And so we've started to collect stories of folks' birthing experience and then really trying to uplift them, because I feel like sometimes the data is important. Like, I'm not a data girl, so I always tell my colleagues, like, y'all got to bring me into the data side. That's not my ministry. Like, I'm the people side. Like, tell me the story. How did that feel? And we need to humanize the data. Like, we need to show, like, this is an actual person. Like, this is their actual body and what it went through. And so we've tried to really start to do that in our storytelling. We have, and we'll get to it as we close, October is Black Maternal Health Month for us in the state of Nebraska. We named it that, and created that intentional deep dive into that space. And a lot of what we're doing outside of supporting practitioners in the space is uplifting narratives around birth stories and your experiences, so we can make sure that you can see the humans that are really affected by this conversation. So thank you for that great question, Sarah. So we have another question, panelists, and it says, can you speak to the connection between closures of OB delivery wards in rural communities and within communities of color from the lived experience of Black women and birthing people?
So yeah, we're definitely seeing more OB wards closing in rural communities. We refer to these as maternity care deserts, and they're not just in rural communities. There are some urban areas that also have maternity care deserts, and that's just measured by the distance between a healthcare facility and the people who need to use it. So some communities may not have transportation, or there just could be a large amount of distance between them and their care facilities. And I would also say that having access to these facilities in the hospital is important, but also having freestanding birth centers are important. I think it's important for families to have access to all different types of birth settings and birth care providers. So whether that's an OB, a midwife, family, in some communities, the family medicine physician is the one delivering babies. So having access to that and having providers that look like us. So having Black providers, Black physicians, Black midwives, and unfortunately, there aren't as many and not as many options. I have been seeing an increase, slowly but surely, an increase in the number of freestanding birth centers that are operated by Black midwives, especially within the last couple of years. I've seen more of those being funded and open. So, you know, in this setting where we're talking about opportunities for funding, that is one area where there's room for growth, with opening more birth centers that are run by Black midwives and that are community-based in their care approach.
Which can get to some policy and advocacy opportunities. You have to check your state regulations on what does that look like. And so sometimes there's intentional created barriers to that given where your state is. And I would say that Nebraska has lots of opportunity to refine our policy and regulations around what that can look like. Thank you, Christian. Any other questions? So I already got the call to actions up because once I clicked it, I couldn't go back and I didn't want to mess up the technology. So y'all kind of get a preview of where we're going, but want to make sure I create space for any other questions that folks may have that have joined us today. So if any questions come up, we're going to go through our call to actions and then kind of end with talking about how do you connect with Ivy Black Girl and then our Black Maternal Health Month. So I'll go and start with my call to action and then I will pass it and popcorn it to my colleagues. So mine is very straightforward. You would think it was simple, but for some reason it seems more complex and nuanced, that you have to center Black women and birthing folks in the leadership, approaches, and solutions, like period. And for us as a collective, as Ivy Black Girl in all of our work, we know that if you center us in whatever it is, whether it's legislation around housing, wages, jobs, you know, the gamut of all the things that folks are trying to tackle and see the opportunities and improvement in, there will be ripple effects for everyone. So when Black women, femmes, and girls thrive, everyone will thrive. And I have found that for us, the opportunity is to really center that leadership, to really center those experiences and voices, to curate the solutions, interventions, and how we move forward. And so I encourage you, if you are folks of color on this call, if you're not of color, if you are a Black person, right? Like, how do you continue to center us in the work that needs to happen specifically around maternal health? Because you would definitely see a change in outcomes when that happens. And I will popcorn it to Christian to do your call to action.
My call to action is to take a holistic approach to funding Black maternal health initiatives. So historically, I would say there's sometimes more attention paid to solutions within the clinical environment, which is important, but looking at how to improve clinical quality and the care that are received within the hospital walls or within the clinic walls. But as we talked about today, that there are so many community factors that impact health. So it's important to also invest funding in community-based programs. As Ashlei said, center the Black women leading these programs. They need resources and solutions to address social factors that impact health. Also looking at like overall well-being. Maternal health starts before pregnancy. It starts pre-conception, from childhood all the way up. Different aspects of our lived experience are going to impact how things go with our pregnancy and postpartum recovery. So looking at impacting funding initiatives that address overall well-being, and then also qualitative research. A lot of times there's focus on funding quantitative research where we have the numbers, we can crunch the numbers and create graphs and pretty graph and data tables. But we also need to listen to the lived experience of Black women. When we're trying to solve these problems in our community, they can tell us what they need. They can tell you how they have experienced living in their community, accessing healthcare, how they've been treated, how they have recovered or not recovered. And I think there needs to be more space and more funding towards those qualitative research that gives space for Black women to share their experience and be a part of the solution.
All right. So my call to action, and I do take this wherever I go because it's something that we even challenge ourselves as my organization. But particularly if you are connected to any organizations or in any positions of power or influence, I think a thorough review of internal practices, policies, and procedures is like vital to making sure that we're doing the work differently. What we do know is all of us, regardless of what type of organizations we are a part of, have been brought up in the United States throughout our life, many of us at least. And for those of us who have been brought up here, we've been raised in systems of white supremacy. So even the systems that have been set up, like our health departments and whatnot that we serve, that are meant to serve the people, sometimes intentionally or unintentionally oppress people. So by reviewing our practices, our policies, and procedures, we're asking ourselves, why do we do what we do? And are the things we're doing actually harming people? And what could we do differently? So taking a health and racial equity lens when we're approaching the work, when we're setting up different policies, when we're setting up like simple things such as like time limits on getting to an appointment or things of that nature, and not thinking about what barriers people may face. It's really looking at it with that lens. And so I included some questions that you could ask with your group that you work with or your organization. How may my institution be intentionally or unintentionally causing harm to Black women and birthing people and communities of color? What opportunities exist for us to serve the community better? So just what else could be done? And also, what support does the organization have from leadership to address issues of health and racial equity? I also want to say I understand that dependent on your organization, you may not have buy-in from the highest level at this time, right? That is a reality that people face. And I always feel like there's always something you can do from where you are. Maybe it doesn't look like a super transformative or drastic change in that moment, but there's always something you can do to challenge, to move things forward, to really think a little bit more critically about what can we do. And so whatever that looks like, if it's as simple as beginning to form a group who start to challenge or look at some of your policies, and maybe it's not going straight to the head right now, but do that. Challenge yourself to do that and think through these questions and approach all of your work from a health and racial equity lens as you are doing this work in maternal health.
So thank you both for that. And so lastly, we want you to keep in touch with us. So please visit our website, shoot us an email, add us on all the social networks. I've also included in the chat a link to our Black Maternal Health page. Let me see if I can do this right. And this is what it looks like. So when you visit our website, you can go to Take Action, and then it'll give you a prompt for Black Maternal Health. And this at the top has our workshops. And so even if you're not based in Nebraska, we have content that is absolutely transferable to your geographic region. So we have our birthing stories. We have conversations around the impacts of systemic racism. Jessica will be there again. So we have information around data like power and choice in the birthing process. We have a ton of on-demand sessions too are already online. And we will also be posting our keynote plenary coming up as well. And so just again, ways to get engaged. Feel free to, this is all free, to network with us for Black Maternal Health Month, as well as lower on our page, we have information around our initiatives and what does that look like. Again, if you're thinking about different models that may work in your geography or just what's happening in other markets as well. So thank you all for attending. We know it's probably a long day. Folks are carrying and navigating a lot. So I hope after this session, you're able to take some deep breaths in, relax those shoulders, drink lots of water, get some rest. And thank you for your commitment to Black women, femmes, and girls, especially in the space of Black maternal health. Thank you.